I'm Michael Lanuti. I'm one of the thoracic surgeons at Massachusetts General Hospital in Boston, Massachusetts. Um, I'm in a rather large division of thoracic surgeons, and I'm the director of thoracic oncology for our division. I have clinical interest in lung cancer, esophageal cancer, mesothelioma, and I also have a translational lab that looks at novel treatments of lung cancer. So does surgery have a role in the histology of small cell lung cancer if it's limited? And the answer is yes. There is a role for curative intent for limited stage small cell, but under specific circumstances. So as we all know, small cell lung cancer is often considered a systemic disease. There are some cases where you define a small cell lung cancer in the absence of nodal disease or in the absence of metastases outside of the chest. So in the circumstances that are shown to be associated with long-term survival using surgery, those circumstances include node negative disease. And what I mean by is the absence of nodal disease in the mediastinum, and ideally the absence of nodal disease in the hilum. Although that's a relative contraindication to surgery, the N1 disease. And of course, the ideal patient is no extrathoracic disease, no metastases in other organs. The important part of the workup of these patients is a comprehensive staging, which includes the anatomic CT, a PET scan. Ultimately, we really want a brain MRI because the small cell has a propensity for brain metastases, and ultimately, the surgeon should do invasive mediastinal staging prior to embarking on any curative resection for small cell. The invasive staging can be done with endobronchial ultrasound or mediastinoscopy, whatever your your expertise is. And of course, there should be there should be PET negative lymph nodes on the PET in those locations. But I must say that even if the PET shows no FDG uptake in the hilum or mediastinum, invasive mediastinal staging is still mandatory to rule out microscopic disease. We have now a few large database reviews, National Cancer Database, the SEER database that try to look at these patient populations to pick out whether we are making a difference for limited stage small cell. And what these studies showed was that if you're going to take a patient for treatment with surgery, that lobectomy is by far the better option than sublobar resection for a limited stage small cell with a mediastinal lymph node dissection. In addition, the best outcomes are achieved in the context of chemotherapy. And in most cases, the surgeons will perform the surgical resection first, followed by adjuvant chemotherapy. There is a debate in this population of whether to do prophylactic cranial radiation, since that is often the first site of recurrence in many of these patients, and that's still under debate.